Hi, this is Jen, and this is week 9. The question of the week is to identify strategies that hospitals and healthcare systems can engage to ensure their population health professionals attain these competencies. What are the challenges faced by hospitals and health systems in developing their population workforce? And what are the public health policy implications? There were several different challenges that showed up in the reading and in when I viewed the video, so I'm just going to kind of hit on a couple here. The first one is, of course, money, finances. It is very important that the healthcare workers understand who's paying the bills, basically. The payer sources can be Medicare, Medicaid, or another form of government funding. It can be a healthcare organization such as McLaren, or up here would be Munson Medical Center, or it could even be a commercial insurance company. Could be a Priority Health or a Priority Health, Blue Cross, different insurance companies that are providing funding for certain tasks, and sometimes those tasks are, you're kind of told what it is. It's for diabetic teaching, it's for healthcare, it's for medication management. You just got to be very conscious of different things and know how each one applies to the patients. There are also many different healthcare organizations who may be helping. Like I said, that's the Munsons, the McLarens, the bigger ones, as part of their not-for-profit status. The first challenge is being able to rely on the money to help with the funding for population health, especially when there are different types of funding. For example, there may be a set amount of money that is in the budget to provide transportation to healthcare appointments. I have seen this one come up often lately. The cost of gas has been rising. Therefore, the money that was in the budget may no longer be enough to provide healthcare transportation to the appointments simply because of fuel costs. The healthcare professional needs to be, for the population, of course, needs to be able to help by being creative with transportation, maybe suggest a carpool, maybe try to get your appointments closer together, or even take public transportation, which is often the case. But that's just one of the examples on how the public health provider or population health provider needs to be flexible and be able to help patients with what they need. I did see one good benefit was the video from the University of Pennsylvania was able to show Penn Medicine, I think I got that in there, Penn Medicine, that they could make $2 for every $1 they spent on community health or population worker program. This is the type of analysis that these public health employees need to be able to do. The type of analysis, it demonstrates a financial return, which will be the best benefit to the public health funding. If we can prove that the benefit of the population health, like I say, when applied, then we can continue to hope to receive funding because we're providing the information on how they're going to get the best return on the investment. Now, we know it's helping the patients, but the people cutting the checks, they might need to know what their return on their investment is and want to make sure it's going to be profitable, either for them long-term or in different ways. Staffing, just basic staffing. I know we're looking to make sure to engage, to get the healthcare professionals, make sure they get their competencies, but just picking the right staff is huge. It's another concern with public health. There needs to be a focus on workforce support. It takes special training to be a population health, public health nurse. I use nurse because that would be a role I would be in, so I will refer to nurse several times in here as an example. Population health leaders need to understand that workforce development and to ask the right questions for the patient and to be able to evaluate a plan of care based on the information they're provided. The workforce has to be able to communicate effectively with the community they serve. So it's going to start with bonding. Knowing how to communicate, of course, is going to be the biggest one here. If the wrong workers are put in the wrong positions, it can lead to a disaster. I do like the example of the healthcare system being an ecosystem, which basically is. It's made up of diverse yet interdependent parts, all that work for the benefit of the patient. Public health agencies are part of that ecosystem. The public health staff member or nurse needs to be able to work independently, but also collaboratively with other parts in the ecosystem. So that nurse has to be trained on how to be able to work with patients and with other healthcare providers, and to know that you got to work as part of the system and to be able to have good people skills. That's not something you can usually train people. Like I said, sometimes if you find somebody who's very good at communication, it's better to train from the inside out, send her to training, because sometimes they naturally have that talent. Sometimes he's just going to be the wrong fit. But like I said, just trying to put the right people in the right spot is a difficult thing, but it's something that needs to occur in order to have benefit. Sarah Schuler, I hope I'm pronouncing that right, is a population health director in New York City at a major teaching hospital. I did like her example. She reports that her strategy is to help her company complete the triple aim. I actually found this to be very interesting, which is something we're all doing: lowering the cost of healthcare, improving patient quality and or outcomes, and improving the patient experience. That's the goal for all employees, the whole program, population health. That's it. We want to get better patient care. She also supports that when starting a program, so when you're first starting out the program, to complete different projects for the community, it'll often require different contracts to be negotiated with different insurance companies. So the nurse or healthcare professional or the population health professional needs to be able to negotiate with different insurance companies, needs to be able to go in there and talk and represent the patients and stick up for the patients in the population there that they represent. In Sarah's case, she is actually the manager, so she is the one teaching everybody, and she's the one handling most of the contracts while she's having the other population health workers complete other things. I think she is a manager, and then she's got other managers underneath her, and then there is, she's the health director, and there's managers underneath her, and then there's workers underneath her, or underneath them. So like I said, she's responsible to train and make sure they all know what they're doing, and then it kind of trickles down. She said it's important to demonstrate and present the benefits of the program, so make sure that everybody knows the benefits of the program. If the goal is to try to increase compliance with medications, then make sure that the staff show how these new programs will encourage patients, for example, to take their medications. So when it comes to taking the medications, also include the numbers on how many patients are non-compliant with medication administration and why. Talk about how you're going to encourage physicians to prescribe maybe generic medications instead of name brand and how much that'll save everybody. This will also help save the patients from having fewer emergency department visits because they're taking their medications. They won't be having the complications from non-compliance anymore, which is a benefit to both. The other thing that Sarah Schuler pointed out is that a priority for the population needs to be the implementation of, she phrased it as technology to accumulate patient data in one system, we paraphrased there, one system or at least one system that can communicate with other systems. This is often a concern that affects patients, medical providers, nurses, specialists, hospitalists, and anybody else who could benefit from seeing the patient's complete his healthcare history. Complete is the main part there. The example they use is if you see Dr. A and you see Dr. B and you see Specialist C, it's most likely that no one has access to the patient's complete medical history. If all this data was available in one place, then it would dramatically improve patient care. It would finally allow the healthcare provider across the whole patient's healthcare the healthcare provider access to the whole patient's health history and not just part of it. I use the example of it's like trying to put together a puzzle, and there's several pieces missing. You got a pretty good idea of what it is, but without the corner in the middle there, you kind of are missing the whole picture. So like I said, your public health nurses and public health staff need to work together to make this one big comprehensive chart. I believe that is something Sarah said she was working on with her team, and that would be something that's definitely needed for public health. What ends up happening is the staff are spending extra time putting what was found in different parts. what's happening is there is the potential for missed information. For example, I actually had this problem occur. If the primary care provider prescribes Lasix, and then the cardiologist looks and sees the kidneys aren't functioning so well, so he prescribes Bumex. The patient could potentially be taking both medications, which could contribute to severe adverse effects for the patient. This could be avoided, though. Nurses need to be trained. It's a good idea to have it be a nurse that's looking over medications. If the patient's health records are available to all the providers who are responsible for the patient, we need to make sure we're looking at the whole picture. We need to get family histories on these patients. We need to get everything that we can to make, or at least to guide them into making good healthcare decisions for themselves. Public health nurses could help the patient manage different appointments with doctors. If a patient is seeing a psychiatrist for their mental health, this is another example. The psychiatrist is prescribing, maybe medication the psychiatrist is prescribing is not part of the chart. I've often seen psychiatrists will still stick to their handwritten notes. There's a few that still do the electronic, but sometimes they have smaller private offices and it's kind of hard. So the public health nurses need to be able to go in there and look and have access to those records. Like I said, if we don't have the information from the psychiatrist starts prescribing the patient new medications. The patient is going to the emergency department now with suicidal ideations. This can be devastating for the patient. And the patient might not remember that, he's taking different medications from a psychiatrist, or he's taken a sample pack from a psychiatrist or something. That's why it's very important to make sure that you get the full picture and all the information there. Like I said, the public health nurse could use the information that the psychiatrist recommends along with the other information to make a more personalized plan of care for the patient, which is our ultimate goal there. This would also give the public health nurse information like emergency room visits and other treatments performed at the hospital. The last concern, and I know I'm getting a little wordy here, but I wanted to make sure that it comes up with public health. The last concern comes up with public health. I heard it in almost all the videos and all the readings is getting the patients involved. Our top thing is that you can have the best program, but if the patients aren't involved and the patients aren't participating, it's not going to do us any good. I really did like the example for Penn Medicine when they did their presentation. However, of course, Penn Medicine did put on the presentation, it appears, and the spokesperson was did work for Penn Medicine. So I did take that with a grain of salt there because I knew the information was going to be biased. However, it looked like she had some very good suggestions there. The greatest suggestion I saw was that the public health nurse sees the patient in the healthcare facilities first, and then follows up with them in their home or outside in a public or wherever they're comfortable at. The public health nurse could talk to the patients in their primary care office, specialty office, or even the emergency department, depending on when the patient gets access to healthcare. Maybe they don't have a specialist. Maybe they don't have a primary care. So it's always just through the emergency department. That's where that employee needs to go. That's where the population health professional needs to go in order to see what the patient needs. The healthcare office or wherever the visit happens at, this is where they can introduce a public health nurse and explain to that, and that public health nurse can take the time to explain the benefits of having that nurse there to help manage his care. The nurse then follows the patient's home or wherever they need to. Of course, good help is always hard to find. But like I said, sorry, my computer's all over here. Different strategies, like I said, hire the correct staff, make sure that we're sharing all the information, and many other different parts here. Like I said, good training, of course, is one. The Penn State Medicine, that was a good thing for training. The book also offers several different ways to collaborate with other professionals and what needs to happen to help out. All in all, this was a good assignment. I liked all the videos. It was very good. The book, of course, is very straightforward. I like our book. It's very straightforward, to the point, and easy to read. Thank you for listening to my presentation.